Alright, so this is the final part of the medical decision-making component. This time we're going to go over risk and then also determining the final code, which should be pretty similar to what we did with the HPI. I think you'll see it's very similar and should be easy to pick up. The risk table that I've got on the worksheet is a lot smaller, and the only purpose was to is really just to conserve space. I'll show you where you can see the larger risk table, and then that way you guys kind of know where the definitive source is. It's actually in three places. I'm choosing to use the Evaluation Management Service Guide off of Medicare's website. I had posted this link, I think, last week. If you guys need me to post it again, that's fine. Just let me know so that way I can get it to you. This is the full table right here. They're divided into 4 categories. On the left, you can see the level of the risk: minimal, low, moderate, and high. And then you've got the presenting problems as a column, the diagnostic procedures ordered, and the management options selected. The way that you do this is that you find what is the type of presenting problem, what are the diagnostic procedures that were ordered, if any, and what were the management options selected. Now each one of those is going to provide a different level of risk, or maybe the same. What you're going to do then is whatever poses the highest level of risk, that's going to be the risk for the whole chart. You've heard me say several times that the lowest guy wins when selecting the code. This is the exception. In this one, whatever is the highest, that's the one that we take. Okay? So I think the best way to do this is just to take the ongoing example and then just take it in terms of the presenting problem, the diagnostic procedures, and the management options. So, the type of presenting problem. You remember when I was defining straightforward in the diagnostic points that I said that it was not a simple problem, but it was something that really the physician shouldn't even be seeing. This is also something that's minimal. Now ours is a case of lightheadedness, and you can get kind of more of a flavor of the kind of the story of what's going on behind that by reading the subjective. Now typically you've already looked at the subjective, so you already have a good idea of what's going on. So this is definitely not minimal risk. Okay, 2 or more self-limited or minor problems. No, that's not what's going on here. 1 stable chronic illness, so if they had well-controlled hypertension, that would be fine. An acute uncomplicated illness or injury. So this is typically where a lot of your urgent care visits fall into. If you have a sprained ankle, or if you have some sort of fall, or kind of trying to think of other examples that I've seen, like a skin lesion, something like that just kind of pops up. Then it would fall into this low risk category. 1 or more chronic illnesses with mild exacerbation. I'm just going to go through these. This lightheadedness would be most likely an acute uncomplicated illness or injury. But 1 or more chronic illnesses with mild exacerbation, progression, or side effects of treatment. So if somebody has diabetes and it's not stable, then that would be considered a mild exacerbation. And so that would be moderate risk. If they have 2 or more stable chronic illnesses, then that would also be moderate risk. An undiagnosed new problem with uncertain prognosis, that would be moderate risk. A lot of what I see that falls into that category tends to be in the cancer arena. So a lump in the breast, or a nodule in an x-ray of the lungs, something where we're really not certain what's going on here. Occasionally I'll see one where it might be a melanoma. For the most part, those are even though we don't know whether they're cancerous or not, I would say the prognosis is more certain. It really just kind of depends on the note. It really could go either way. And then acute illnesses with systemic symptoms. Okay, so basically if somebody comes in with a cervical strain in the neck, but they have numbness and tingling in their upper arms. That is a problem where we would say that's an acute illness with systemic symptoms. The reason is because typically when you've hit the back of your neck and your upper arms start tingling, it's a sign that there is nerve damage done to the cervical area of the spine. And so it's a little bit more of a serious problem. Acute complicated injury, so a head injury with brief loss of consciousness, so somebody has a concussion and they're knocked out, that would be an acute complicated injury, which would be moderate risk. High risk is something that typically in a physician's office you're not going to see much of. So one or more chronic illnesses with severe exacerbation, progression, or side effect of treatment. That would be somebody, say with hypertension and their blood pressure is like 200 over 180. They call that hypertensive emergency, and that is a severe exacerbation. You run the risk of running into organ failure with that particular condition with that severe of an exacerbation. Acute or chronic illnesses that pose threat to life. So if somebody's having a heart attack, that would be a really good example. Notice about halfway through that list, they've got progressive severe rheumatoid arthritis. It's important to note that progressive severe. The severe is the key word. A lot of people will come in with rheumatoid arthritis. It's being followed up by a rheumatologist. It doesn't matter that they just have rheumatoid arthritis, but that it's progressive and it's severe. And an abrupt change in neurological status. This actually did happen with a patient in our office where the nurse roomed the patient, they were fine, and the physician came in and they collapsed on the floor. That is an abrupt change in neurological status. And so that would fall into the into the category of high risk. Okay, with our problem here, we've got lightheadedness. Now, the physician, just by looking in the assessment, says most likely due to volume depletion and poor food intake. We know that for ICD-9 coding, we can't go off of most likely, but in trying to determine what the risk is of this patient, most likely is okay to look at and consider. If it's something to volume depletion and for poor food intake, it's probably not hugely severe. And the note, or the flavor of the note, kind of indicates that. So I would say that for the presenting problem, this would be a low risk. That it would be low risk for the presenting problem due to that it's an acute, uncomplicated illness or injury. The next is the diagnostic procedures ordered. For the most part, these are self-explanatory, so I'm just going to dive right into the example. We've got a whole bunch of labs. Lab tests requiring venipuncture, urinalysis, or ultrasound. All three of those are legit. So according to the diagnostic procedures ordered, it's actually minimal risk. But we do have low risk for the presenting problems, so we know it's not going to be minimal. It will be at the least a low risk problem. Physiological tests not under stress, so it'll just be a regular pulmonary function test, like a spirometry or something like that. Non-cardio or non-CV imaging studies, superficial needle biopsies. And these are things that they would do as procedures that are not in the normal range of laboratory and imaging tests. For moderate risk, stress test would actually count as moderate risk. Diagnostic endoscopy, so like a colonoscopy would count in that. Deep needle biopsy, CV imaging studies with contrast, or obtaining fluid from a body cavity like a lumbar puncture or thoracentesis. These are things that you're not typically going to see done in the office. Typically they'll be referred, and they'll do it in a hospital where they have a more sterile environment. For high risk, it would be a cardiovascular imaging study with contrast, or a cardiac electrophysiological test, or discography. These things are pretty serious. They're borderline surgeries, not just diagnostic tests. So we know that for our patient that we're evaluating now is that it's typically in the minimal category. So then we'll go ahead and go on to the management options selected. And that basically comes down to what did they tell the patient to do. advised the patient to increase fluids and have 3 meals per day. That was the management option selected. So for minimal risk, in the risk table we've got rest, gargles, elastic bandages, superficial dressings. For the low risk, we've got over-the-counter drugs, minor surgery, physical therapy, occupational therapy, IV fluids without additives. And I'm going to stop right there and refer to the example. The example, I believe, would be minimal risk, even though it's not there. I mean, telling somebody just to make sure you eat 3 meals a day and to make sure that you stay hydrated, that is going to be minimal risk. I mean, it falls kind of in that rest category. If they had said, go to the store, if you got like a back sprain and take some ibuprofen, then you would consider that over-the-counter drugs. And I say that because in the moderate risk, I want to point out something that happens nearly every visit, and that is prescription drug management. Prescription drug management happens, I would say, 85-90% of all the visits that happen. And usually physicians are really good about documenting that. What constitutes prescription drug management? Anytime you start a new med, obviously. Anytime you change the dosage or discontinue a medication. I think those are the obvious examples. But even if you say continue current meds, or if you say, we're going to try a trial, those also constitute prescription drug management. Now, ibuprofen. Ibuprofen does come in prescription strength. It will depend on your office and the policy of that office as to whether or not you're going to count that as prescription drug management. Now, at our office, we don't, and the reason is because it's the feeling of the leadership team that patients, if they want prescription level ibuprofen, can just take more pills, and so it's not really prescription drug management. But anyway, so typically what I will do is, if I'm looking at a chart, I will look for prescription drug management. Also, something else to keep in mind is the prescription drug management does not have to do with current conditions that aren't being evaluated. What do I mean by that? Somebody comes in for a head cold, a URI, and they're also diabetic, hypertensive, hyperlipidemic, and the physician says, okay, you know what, your head cold is just a head cold, go ahead and continue your current medications. That is prescription drug management, even though it's not related to the presenting problem. So if you're going to look, I would strongly suggest, just for your own sanity and for saving time, look through the charts and see if there's anything that says continue current meds or any sort of medication management, because you've got moderate risk. Then the only question is, okay, do I have high risk? And chances are probably not, but it is possible. So minor surgery with identified risk factors. So if you're doing a toenail excision, obviously this doesn't count, unless they've got gangrene in the rest of the foot. Then okay, now you've got a risk factor, but it has to be identified in the note. Elective major surgery, therapeutic nuclear medicines, IV fluids with additives, or closed treatment of fracture or dislocation. Remember, closed treatment is they're not taking a scalpel and actually opening it up to work on it. They're trying to manipulate things in place. And then high risk would be elective major surgery or emergency major surgery. Decision not to resuscitate or de-escalate care because of poor prognosis. Typically, like I said, you're not going to see these things in an office. Although, for some of these, if more for the presenting problems, if they go to the emergency room for a heart attack and then they come into the office, that would be high risk, because it would be the presenting problem. Okay, so if you have any questions on that, or if you look through the note and you're not sure where something might fall in, go ahead and shoot me an email and I will try to walk you through it without giving you the answer, of course. And whether you use the worksheet or this risk table is up to you. It's just going to depend on what your comfort level is. So we said that this was low risk. So we're going to highlight this. And now what we're going to do is we're going to find what the level of medical decision making is. Now I want you to notice something very carefully. Right up here at the top it says medical decision making 2/3. Remember the HPI, we had to use all three components. Well, with the medical decision making we get to drop one, which means we get to ignore it in considering what the care is. Right now, if we were to look at it and we didn't drop one, our medical decision making would be straightforward. And the reason it would be straightforward is because of this data, but since we get to drop one, and it's completely up to us which one to drop, most likely we're going to drop the one with the lowest value, which is the data. So then we drop the data, and then we get to the low complexity visit for medical decision making. Okay? You will think that you see a trend, and this happens with physicians, and I'm betting it will happen with students as well, that the medical decision making and the risk parallel each other often. They do. I don't want you to think that they don't. You'll notice I've got low risk and low complexity. Where it can really goof you up thinking that way is when the diagnosis points are lower than the risk. Let me give you an example that I see quite often. You have a diabetic patient whose hemoglobin A1C is 9.0. That is uncontrolled. Okay, so I've got one problem, uncontrolled, right? And it's 2 points each, and I've only got one problem. There's no hypertension involved, no hyperlipidemia. So now it's 2 points. I'm going to highlight this green so that way visually you can see it. Okay, we're going to keep this the same, the data. Okay, but then they say that it's moderate risk because we got prescription drug management. You know, they'll say continue current meds, or they'll say, you know, we're going to adjust this medication in light of poor management. Now you see what's happened is that we have fewer diagnosis points than we do the risk. Well, what that's going to lead up to is the lowest guy wins. Remember that? Okay. For our yellow example, we drop data. We've got 4 diagnosis points, which is high complexity, and we've got low risk, which is low complexity. We take the lowest one, and that's how we arrive at the low complexity. For this one, though, it would be very tempting, if you see it, to say, okay, it's moderate risk, therefore it's moderate complexity. But you forget about the diagnosis points. If the lowest guy wins, diagnosis points is low complexity, moderate risk, moderate complexity. Well, now it's going to be low complexity because of the diagnosis points. So keep in mind that risk and medical decision making frequently do go together, but not always. And it happens just enough to where you need to be aware of it. All right? So that's what it is for medical decision making. Go ahead and do the assignments on Kia. Due to the problem that we had with the partial credit last week, I think you'll be happy to know that it's all multiple choice. And I think the answers will be much clearer and much more defined. And I'll try to straighten out the mess with the exam portion just because it's kind of funky. Next week what we'll be going over is we'll be putting all this together in selecting a code, an actual E&M code, and we'll go over the difference between an established patient and a new patient in particular. Perhaps consults, I'm not convinced of that yet. Somebody made a comment that, you know, given the amount of time that we're spending on E&M codes, are there going to be a lot of E&M codes on the exam? The answer is actually probably not. And here's why. E&M codes are incredibly complex. You need to be able to know how to evaluate the HPI, the exam, and medical decision making. And then you take that information and then apply it to find a correct level of service. Now, if you look in your CPT book, it's not just the office visit codes, it's also the inpatient codes. On the exam, the final exam, it's going to be a mock-up of the AAPC's CPC exam. And what they do is they don't tell you that the HPI is problem focused, the exam is detailed and the medical decision making is low complexity. What they will do is they will say, okay, here's the HPI. They'll usually tell you what the exam is because there's so much ambiguity that could happen there. And then they'll say, okay, this is the patient's first time seeing a provider for this particular problem, and the provider prescribed medications. And then it's up to you to determine the correct level of service. So that's why we're going over it so much in detail, is because it is very complicated. All of the arguments typically that I see with auditing that go on happen over E&M codes. Rarely does it happen over a procedure. Most likely it'll happen over an E&M code, and that's where people get into a lot of trouble. So it's very important to understand this. In my office, I would say that E&M coding makes up probably 75% of what I do. So even though on the exam you're not going to do it, and in specialty it's about 60%. So even though it's not as much, it's still going to be a significant portion. So this is for your benefit, and also so that way you can understand what's going on with the exam, so that way you can come to a correct level of service. If you have any questions, shoot me an email, or if I'm online for instant messaging, let me know that too. I did find a way to kind of incorporate MSN, and I have an MSN account now, so I just need to add people to my friend list for you guys. So I'll be doing that sometime this week. It's kind of a busy week for me, but I will try to do it earlier in the week rather than later. Also, this Wednesday is our face-to-face gathering. Please don't forget that. If you need directions, again, let me know, and I will send them to you as soon as possible. Until next time.